Hello, my name is Paul Simonelli, Chair of Pulmonary Critical Care Medicine at Geisinger. I would like to spend a few minutes discussing the significance, recognition, and initial treatment of COPD exacerbations. Chronic obstructive pulmonary disease is a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation due to airway and alveolar abnormalities usually caused by significant exposure to noxious particles or gases such as cigarette smoke, air pollution, or occupational exposures. COPD can also be characterized by inflammation of the airways, excess mucus production, and swelling of the mucous membrane linings of the airways, all of which combine to restrict airflow within the lungs. Other associated conditions include genetics, aging, gender, history of severe lung infections, and social economic status. Many people with COPD have other concomitant chronic diseases which contribute to excess morbidity and mortality, which include heart disease, skeletal muscle dysfunction, metabolic syndrome, osteoporosis, depression, anxiety, and cancer. There are several classification schemes of COPD. The most common is the Global Initiative for Obstructive Lung Disease, GOLD, classification, which divides the disease into 4 categories based on severity. The purpose of this discussion is not to make a diagnosis, but rather to review steps that should be taken when people who already have a diagnosis have an exacerbation. Symptoms of a COPD exacerbation include increased wheezing, diminished airflow, increased mucus production, coughing, increasing shortness of breath, fatigue, and sometimes fever. COPD exacerbations are a common reason for emergency room visits and hospital admissions if not recognized and treated quickly and efficiently. In fact, this is one of the main causes for hospital admissions in the Keystone ACO. Appropriate long-term treatment, including smoking cessation, avoidance of noxious stimuli, and appropriate medications, mostly in the form of inhalers, can keep people well and out of trouble. When exacerbations do occur, however, the patient should be educated to seek attention promptly. Ideally, people who have been previously diagnosed will have a rescue kit on hand, which includes an adequate supply of rescue inhalers, a prescription for a short course of steroids, and a prescription for antibiotics should they become necessary. The patient should be educated that once their sputum production increases or they begin wheezing, they should contact their physician's office and begin the rescue medications if available. Many people choose to wait a few days to see if they will get better, but most often they will continue to worsen unless appropriate steps are taken. When seen in the office, these people generally appear acutely ill with rapid respiratory rate, tachycardia, wheezing, and sometimes fever. On examination, they typically will have inspiratory and expiratory wheezing and coarse crackles throughout their lung fields. The goals of acute therapy are prevention of further worsening, a return to baseline as quickly as possible, and a prevention of a recurrent exacerbation. Initial treatment targets airway inflammation, bronchospasm, and treating infection. Rescue inhalers such as albuterol or ipratropium should be prescribed initially, and the patient should be instructed of their use. If the patient is significantly dyspneic, then a short course of oral steroids should be prescribed. Current guidelines indicate 20 to 40 milligrams of prednisone or its equivalent daily for 5 days. It is estimated that approximately 1 out of 3 COPD exacerbations are related to bacterial infections, and if the patient has significantly increased sputum production, change in color of sputum, or fever, then empiric antibiotics should be administered. Appropriate antibiotics include azithromycin, doxycycline, augmentin, sulfomethoxazole trimethoprim, or levofloxacin. Patients should be encouraged to continue the usual maintenance inhalers as well. If not yet prescribed, the use of long-acting inhalers should be considered to treat the exacerbation and to help prevent a recurrence. These inhalers include long-acting antimuscarinics, LAMA, tiotropium or umeclidinium, long-acting beta agonist, LABA, salmeterol, vilanterol, or formoterol, in combination with an inhaled corticosteroid, fluticasone, budesonide, or a LAMA plus a LABA. Patients should be monitored for signs and symptoms of respiratory failure, including respiratory rate greater than 30, use of accessory respiratory muscles, hypoxemia, oxygen saturation less than 90% on room air, or hypercarbia, which could be manifested as mental status changes. For people who have symptoms of respiratory failure, such as a change in mental status, worsening hypoxemia not corrected with low-flow oxygen, or evidence of respiratory acidosis, hospitalization is necessary and possibly placement in the intensive care unit. These patients should be seen back in the office and reassessed in 1 to 2 days. Smoking cessation should be emphasized. Pulmonary consultation should be requested on an urgent basis if the exacerbation does not respond within the first 48 to 72 hours and for ongoing care as the disease progresses. As patients improve, they should be seen again in 7 to 10 days. If they are improving, consider changing to long-acting inhalers per GOLD criteria. At every interaction, smoking cessation should be emphasized. These patients should be followed closely and regularly, perhaps every 3 to 4 months on an ongoing basis. Their symptom burden, which is best captured using the CAT and MMRC questionnaires, and the frequency and intensity of their exacerbation should be monitored at least yearly. This will allow stratification of their COPD using GOLD criteria and to then better align appropriate therapy for their condition. They should be offered screening thoracic CT scans when appropriate due to the relationship of lung cancer with cigarette smoking. Pulmonary consultation with possible co-management should be considered for any COPD patient who remains with a high symptom burden, exacerbates frequently, or who has complex comorbidities. We owe it to our patients to provide appropriate education about tobacco cessation and to stay up to date on current developments in the treatment of COPD and to keep them as healthy as possible and out of the hospital. A smart set has been developed for use in EPIC number 14363, which includes choices for acute as well as chronic care of COPD patients. Thank you.